So after acquiring the data by the history, physical, and the diagnostics, you need to identify key features. What are the key features? The key features are individual elements of the patient's data which are likely to help differentiate one diagnosis from another. Let me give you an example. A patient complains of chest pain. Severity versus the relation of pain to something. Which one do you think is a key feature? Is it the severity of the pain or the relation of the pain to something? Severity. If the patient complains of severe pain, this will not point to a certain diagnosis because pleurisy can result in a pain as severe as the pain of a heart attack. While the relation of the pain to the respiratory movements, the relation of pain to breathing, this is gonna point to pleurisy. While the relation of pain to exertion, this is going to point to ischemic heart disease. Therefore, the relation of pain to a certain event is going to be the key feature and not the severity. And key features could be positive or negative findings that will help us differentiate. And it should be derived from, as I said, the history, examination, labs, other tests, and chart review. Then the third step, and one of the very important steps, is how to create a problem representation. And this is a 1 to 2 sentence summary using precise medical terminology of the most highly relevant aspects of the patient's history, exam, and diagnostic tests. And when you put a clear problem representation, this is going to be a very crucial step in reaching or in creating differential diagnosis. And we have to use semantic qualifiers. What are these semantic qualifiers? These are simply distinguishing adjectives. And then we should synthesize the related findings into clinical syndromes. So let me talk about these semantic qualifiers and give you some examples. These are kind of distinguishing adjectives of the patient's symptoms, and they help reframe the patient's symptoms into familiar clinical terms, like onset. The semantic qualifiers for onset could be abrupt versus progressive, acute versus chronic. Course, it could be continuous or episodic. For the site, it could be unilateral, bilateral, diffuse, localized. For the trigger, what triggers the symptoms? It could be postprandial, exertional, pleuritic, or positional, and the presence of pain or not. Let me give you some examples here. When the patient says, for the last 30 minutes, my chest has hurt whenever I take a deep breath. How are we going to put these patient's words in some semantic qualifier form? So I can say acute pleuritic chest pain. So this is distinguishing adjectives for the patient's symptom. Over the past several months, both legs have been getting weaker and weaker. Then how to put it in semantic qualifier terms is going to be chronic, progressive, bilateral, lower extremity weakness. And then we try to synthesize the symptoms into clinical syndromes whenever possible. Like a patient with confusion, fever, tachycardia, tachypnea, leukocytosis, and surgical wound infection. It sounds like what? Yes, it sounds like sepsis. Or patient who is alcoholic and jaundiced with ascites, confusion, asterixis, and total bilirubin of 2.5 and INR of 2, which is elevated. It sounds like cirrhosis and liver cell failure. Perfect. So this is how we try to synthesize the problem representation into clinical syndromes. The structure of the problem representation. We start the problem representation statement or these two sentences with age and gender, then highly relevant past medical history, then the primary symptom or symptoms using semantic qualifiers, and followed by the highly relevant diagnostic data using clinical syndromes whenever possible. Let me give you some examples. A 60-year-old woman, age and gender, with a history of poorly controlled diabetes, highly relevant past medical history, presents with chronic progressive exertional dyspnea. Dyspnea is the symptom. Chronic, progressive, exertional, these are the semantic qualifiers for this symptom. With exam and chest x-ray findings of volume overload and with unremarkable routine labs and AKG. These are the highly relevant diagnostic data found in the patient's story. Another example for the same structure of problem representation. A 62-year-old man with diabetes and alcohol dependence presents with acute, constant epigastric pain associated with nausea and vomiting. Pain or epigastric pain is the primary symptom and all the rest were semantic qualifiers. Found to have SEERS, severe epigastric tenderness, and a lipase of 800. These are the highly relevant findings in the patient's data. You might think that the chief complaint and the problem presentation are one and the same thing. Actually not. They are close, kind of close, but they are, that's why I put them for you in one slide here. And let me give you one patient. How do we state his chief complaint and how do we state his problem representation? Don't forget, the chief complaint is age and gender, but followed by the highly relevant past medical history, plus primary symptom, plus duration. So for this woman, it could be something like that. Miss S is a 55-year-old woman with a history of metastatic breast cancer, presents with dyspnea and chest pain for 2 hours. When it comes to the problem representation, I'm going to use the first two boxes. Miss S is a 55-year-old woman with a history of metastatic breast cancer presenting with, now I'm going to use semantic qualifiers, acute, constant, non-positional dyspnea associated with pleuritic chest pain, found on exam to have hypoxia, normal chest x-ray, and evidence of right heart strain on exam and AKG. This is how we put the patient's chief complaint versus the problem representation.